Welcome to another pediatric lesson, everyone. My current lesson is about gynecomastia. Gynecomastia is the proliferation of mammary glandular tissue in the male, and it is a common condition. True gynecomastia, or the presence of glandular breast tissue, must be distinguished from pseudogynecomastia, which is the result of accumulation of adipose tissue in the area of breast that is commonly seen in overweight males. So in overweight males, it is pseudogynecomastia. It is due to the accumulation of adipose tissue in the area of breast, whereas true gynecomastia, it is the presence of glandular breast tissue. So we should have to distinguish just two things. True gynecomastia is characterized by the presence of a palpable fibroglandular mass at least 0.5 cm in diameter that is located concentrically beneath the nipple and the areolar region. There are different types of gynecomastia. From this, physiologic and the pathologic gynecomastia is the most common one. Physiologic is also classified into neonatal gynecomastia and pubertal gynecomastia. Gynecomastia occurs in many newborn males as a result of normal stimulation by maternal estrogen. The effect usually disappears in a few weeks. It is then extremely rare in prepubertal males, in whom it should always be investigated to identify the cause. But it again becomes common during normal puberty. So physiologic forms of gynecomastia is common during neonatal period and pubertal period. When we see neonatal gynecomastia, transient gynecomastia occurs in 60 to 90% of male newborns secondary to exposure to estrogen during pregnancy. And the breast development might be asymmetrical, and galactorrhea is seen in approximately 5%. And most cases resolve within 4 to 8 weeks of birth, around 1 to 2 months of life, but a few can last as long as 12 months. This is an image of a baby with having neonatal gynecomastia, which is benign breast hypertrophy. This is a benign condition that subsides itself within 1 to 2 months. When we see pubertal gynecomastia, during early puberty to mid-puberty, up to 70% of males develop various degrees of subareolar hyperplasia of the breasts. Incidency peaks at 14 years of age or at Tanner stage 3 to 4 and at the testicular volume of 5 to 10 ml. Physiologic pubertal gynecomastia may involve only one breast, or it is not unusual for both breasts to enlarge at disproportionate rates or at different times. Tenderness of the breast is common, but it is transient, and spontaneous regression may occur within few months, and it rarely persists longer than 2 years. Significant psychosocial distress might present, especially in obese males with relatively large breasts, and the cause is thought to be an imbalance between estrogen and androgen action at the level of breast tissue. Testing usually fails to reveal any significant difference in the circulating estrogen and androgen levels between affected and unaffected males, but minor degrees of imbalance in free hormone levels might still be present. So the main difference of estrogen and androgen is at the level of acting as the breast tissue rather than the total body level. Other hormones, including leptin and luteinizing hormones, might directly stimulate breast type development, and it might play a role in pubertal gynecomastia. Some cases might be caused by an increased sensitivity to estrogen and or relative androgen resistance in affected tissue. So certain people might be resistant to the effect of androgen, whereas others might be due to increased sensitivity to the available estrogen, even though it's normal. As androgen levels continue to rise in the late puberty, most cases resolve and no specific treatment is needed. The second one is pathologic gynecomastia. Monogenic forms of gynecomastia are extremely rare. Familial gynecomastia has occurred as an X-linked or autosomal dominant sex-limited trait, and some of these cases were found to be caused by constitutive activation of the P450 aromatase enzyme, leading to increased peripheral conversion of C19 steroids to estrogen, or increased peripheral aromatization. Excess aromatase activity was shown in skin fibroblasts and transformed lymphocyte in vitro. Exogenous sources of estrogens are an important cause of gynecomastia in prepubertal children. Very small amounts of estrogen can cause gynecomastia in male children, and accidental exposure might occur by inhalation and percutaneous absorption and also ingestion. Common sources of estrogens include oral contraceptive pills, and oral and transdermal estrogen preparations. Gynecomastia can also occur secondary to exposure to medications that decrease the level of estrogen, especially the free androgens and those that increase estradiol or those that displace androgens from breast androgen receptor. Spironolactone, alkylating agents, anabolic steroids, human chorionic gonadotropins, ketoconazole, cimetidine, androgen inhibitors such as flutamide are all associated with the occurrence of gynecomastia. Weaker associations are seen with a large number of other medications and drugs of abuse, including opioids, alcohols, and marijuana. Klinefelter syndrome and other causes of male hypogonadism are strongly associated with gynecomastia. Significant gynecomastia is seen in 50% of adolescents with Klinefelter syndrome, and it is also seen in other conditions characterized by male underviralization, including partial androgen insensitivity syndrome and 70-ketosteroid reductase deficiency. Gynecomastia has also been observed in children with congenital viralizing adrenal hyperplasia, like 11-beta hydroxylase deficiency, and with Leydig cell tumors of testis or with feminizing tumors of adrenal gland. When gynecomastia is associated with galactorrhea, a prolactinoma should be considered. Hyperthyroidism alters the ratio of androgen to estrogen by increasing bound androgen and decreasing the free testosterone. This might result in gynecomastia in up to 40% of cases. Gynecomastia is also seen in malnourished patients after restoration of normal nutrition or refeeding syndrome, in which it might result from hepatic dysfunction or abnormal activation of the gonadotropin axis. When we see about evaluation of gynecomastia at clinic, in pubertal cases, a detailed history and a physical examination might all that is needed to exclude rare pathologic causes. Historical evaluation should include family history of male relatives with gynecomastia, history of liver and renal disease, use of medications or drugs of abuse, exposure to herbal and cosmetic products that might contain estrogens. And physical examination should include special attention to the breasts, looking for overlying skin changes, fixation, local lymphadenopathy, nipple discharge, as well as testicular exam. No laboratory evaluation is indicated in routine cases with no other associated abnormality. However, all prepubertal cases are, as well as pubertal cases with suspicious features, should be investigated. Initial laboratory evaluation should include thyroid function test, because up to 40% of patients with hyperthyroidism have some breast tissue hypertrophy, testosterone level, estradiol, human chorionic gonadotropin, luteinizing hormone, and the prolactin level should be checked. Because of the circadian variation, this level should ideally be obtained in the morning. Other tests that might be indicated in selected cases include a karyotype, dihydropendasterone sulfate, liver and renal function tests. Gonadotropin levels might also be useful screen for Klinefelter syndrome and will be elevated in pubertal males with this condition. And if they are elevated, a karyotype should be performed to confirm Klinefelter syndrome. Regarding treatment in case of benign pubertal gynecomastia usually consists of reassuring the boy and his family of the physiologic and the transient nature of the phenomena. When the enlargement is streaking and persistent and cause serious emotional disturbance to the patient, specific treatment might be justified. Unfortunately, medical treatment is generally ineffective in long-standing cases. Early cases respond better to medical treatment, but it is then harder to justify as most cases will resolve spontaneously. Agents that have been used for medical treatment include androgens, aromatase inhibitors, estrogen antagonists, and the like. Estrogen antagonists like tamoxifen and raloxifene are more effective, with raloxifene being the superior agent in at least one well-designed trial. If medical treatment is attempted, it should be in early cases less than 12 months standing, or it should be as early as possible with one of either raloxifene or tamoxifen for 3 to 9 months. Overall, success rates are generally low in severe cases, and that of mild cases will likely resolve on their own without treatment. In those cases where breast development is excessive and when they cause significant psychological distress, failure to regress in 18 to 24 months, surgical removal of the enlarged breast tissue might be indicated, particularly males who have completed or nearly completed pubertal development. Careful examination and the laboratory testing to exclude non-physiological causes are advisable before proceeding to surgery. Thank you for your attention. Don't forget to subscribe to the channel. Have a nice time.